Good morning and wishing you all a happy International Pathology Day. So before we begin this guest lecture, may I request Professor Dr. Sandhya Sundaram, Head of the Department of Pathology, Sri Ramachandra Medical College and Research Institute, to welcome the gathering. Over to Madam. It's not here.
No, start.
We are not able to hear. What is it?
Did you want me to start, sorry?
Just 1 minute.
Yeah, sure. No problem.
Yeah,
Thank you for giving us this time. And all our candidates and thank them for their keen support. I welcome our pathology colleagues, my teachers, our students, past and present, for their immense contribution on this International Pathology Day. I welcome our speaker, Kristen Rutland, and all my colleagues for the department, with special mention to Dr. Balaji, Organizing Secretary, Dr. Pavitra, our Additional Coordinator, and Dr. Rajesh, who connected with our speaker and made this happen. And as a proud pathologist, I give you the small phrase: without pathology, there is no medicine. Without diagnosis, there can be no treatment. And today, pathology has moved way beyond diagnosis to prognosis, diagnosis, to monitor, digital, to microsatellites. I now invite our beloved Vice Chancellor, Dr. PVD Sir, to inaugurate the session. I am ever so thankful that he is here with us today on this momentous occasion. Professor PVD Sir, can you open the session with your encouragement? Thank you so much.
Yeah. Yeah. Good morning, everyone. Dr. Rutland from Australia, Dr. Sandhya Sundaram, the head of the Department of Pathology here at Srihar, Dr. Rajendran, Professor of Pathology here at Sri Ramachandra Medical College, Dr. Bharati, Dr. Pavitra, all the other faculty members of the Department of Pathology, and participants, which I now find has already crossed the figure 119, as I see. Um, Good morning to everyone. I bring greetings from Sri Ramachandra Institute of Higher Education Research on this International Pathology Day. The months of October and November have got a lot of international days, and I'm very happy to find that pathology has also joined the bandwagon to have this celebrated. Just for the information of Dr. Ratlan, I thought I'll give a short introduction of our university, which you might have got from some of the faculty members in pathology. We actually started as a medical college way back in 1985 and have moved on to become a renowned healthcare university with about 7,000 students and about 150 different programs. Our first program that we started was the MBBS program, and today we have almost 150 different programs, including the recent addition of a faculty of engineering. It is not a run-of-the-mill engineering college. It has got a lot of application towards healthcare, and this actually is in the field of computer science. We get graduates who are trained in artificial intelligence, in cybersecurity, and also in biomedical engineering. Of course, this is a very young new baby, was born only last year, and we would see the end results of this particular effort maybe in the next 4 or 5 years. Our university cares for quite a lot of quality initiatives, and we participate in a lot of national and international accreditation frameworks work, and we submit all our details and we get a ranking. And the National Assessment and Accreditation Council has repeatedly given us a very high rank amongst healthcare universities, almost the top one, with a CGPA of 3.62 upon a maximum of 4. And we also have participated in the National Institutional Ranking Framework, which has actually got our university the 28th rank amongst nearly 1,700 universities in the country. And we also, the medical college stands out in actually getting the 13th rank amongst nearly 300 medical colleges. Of course, the total number of medical colleges in India is 591, and 300 only. This is a voluntary exercise which institutions choose to participate, and on that ground, we are fairly high up. And the pharmacy as well as the dental college are also in the high rank list. I am extremely happy that this International Pathology Day, Dr. Sandhya actually chose to celebrate it by having a webinar which is addressed by a great expert on colorectal cancer. I know that we all get worried with youngsters when they get ulcerative colitis or Crohn's disease and things like that. And they are the ones which are at high risk to get colorectal cancer. And the title, I was amazed to find a title like, I don't know whether it's Rutland's talk title, from mummies to microsatellites. That means he's probably going to take us back 1,000 years to what is going to happen now. And it's quite interesting to know the talk in terms of the pathological aspects. As a clinician, an orthopedic surgeon, I always have regarded that pathology plays a very important role in healthcare, because the final diagnosis always lies with you. And depending on what is the diagnosis that we get, the management strategies keep differing. And if you want to follow the latest state-of-the-art management, the pathological diagnosis, not only in terms of the histology that you see under the microscope, but a lot of molecular details are being studied now. And probably the immunohistochemistry plays a much higher role in terms of deciding the management. And to that extent, I am happy that seminar or a webinar of this nature is going to give us a lot more inputs and information. I am happy to find that Dr. Ratlan actually comes from Liverpool Hospital, and I'm going to connect this. I always thought Australia and England never saw eye to eye on many things, but I also had the chance to be trained for my MCH auth from the Liverpool University and the Liverpool Hospital, the Royal Liverpool Hospital in the UK. But probably there is one Liverpool hospital that exists in the Western Sydney University as well, where I find Rutland is probably connected with that. So I'm able to see a lot of connect between the institutions that we come from in different under different circumstances. I would stop here, and I'm extremely happy that this webinar has attracted a lot of people. I'm sure a lot of people from not only Ramachandra, but from across the whole country and also across the world will be actually listening to this talk. And I'm sure the organizers have provided some interaction time so that they will be able to clarify many of their doubts. I wish this particular program all success, and I'm very happy to formally inaugurate this webinar. Thank you.
Thank you so much, sir, for those kind words. May I now request Professor Dr. S. Rajendran to introduce the speaker.
Hi, good morning to all. To start with, a very happy International Pathology Day. And it's my pleasure to introduce my good social friend, Tristan. I have not met him, but I don't know whether he meets me, he will be this friendly to me or not, I'm not sure. But he's a very famous tweeter. And as you know, he is in Australia. He's working as a lecturer in pathology in Western Sydney University. He holds his fellowship from Royal College of Pathologists of Australia. And a lot of laurels. To me, he's not a human being, but he is being human. That is more important. And he is very empathetic to the pathology trainees. He always, for the trainees, which is very rare to find nowadays. And he's a teacher par excellence. Even talking about his teaching abilities, just yesterday he got the Best Teachers Award from Western Sydney University. Congratulations, Tristan. And he's very much interested in traveling and history. That's why I think he got that mystery in his topic, Mummies to Microsatellite. He loves painting, and I hope he will paint a very nice picture for us today. And I hand over the mic to Tristan. Thank you very much for accepting this, and we are very lucky to have you today. Thank you, Tristan.
Thank you very much. Thank you all, and thank you, Vice Chancellor. Before I start my speech, just to tie it back in as well, there is a lot of connect between Australia and the UK with names. And I actually went to the UK once, and I actually found that there's not only a Liverpool, but there's a Newcastle. And in fact, there's my little own hometown that I went to, that I grew up in, was named after a town in England as well. And everyone used to get very confused in where I came from. I used to think that I came from this English town as well. So I think there's a lot of crossover there as well. I think it's quite unique. But my talk today is going to be on colorectal cancer, and I am coming from it from a historical point of view, but to actually bring us up to the future and present, and talking about what's gone before and how we can learn, and how it's also shaped what we do in pathology, and how it's shaped treatment, and where it's basically taking us as well. And I notice the Vice Chancellor mentioned that he is an orthopedic surgeon, and my first slide, actually, let's put it on here, is actually a fun fact that I found, which I find people might find interesting, is that the first recorded case of metastatic cancer ever was found in a dinosaur bone as well. So, and this wasn't histological, this was actually done with x-rays, and a paleopathologist actually did this as well. And I thought we're just talking about cancer, and we talk about how far back we're going, we can go back millions of years and show that cancer has been something that has actually existed within, essentially, since life has been around. It's essentially a side effect of being alive. Unfortunately, it's what's driven our evolution. But we can see that here, this is a cross-section of a bone, and this is the X-ray, and it has that lytic lesion. So I thought that was a little interesting fact that I came across when I was preparing for this as well. But going on to where my title of my talk begins, is the real first, and we're talking about pathology in particular here, of confirmation or histological confirmation of particularly metastatic carcinoma. And it was it's a toss-up between, was this a rectal carcinoma or a lung cancer? But this is the rectal carcinoma they found in a liver section here. And I don't know if you can see I'll get my little pointer out here as well. And you can see my pointer here, I think. This bottom panel here actually shows, this is a histological section from a mummy, and actually this is metastatic carcinoma from the rectum in a mummy liver as well. And this is just the top one is to show you what a normal, well, not a normal, what metastatic carcinoma looks like in a normal histological section. This is a malignant gland in the top one. If you can see my pointer, I hope so. Let me know if you can't see the pointer. I'm going to actually draw on this. That's even better. Yeah, so up here. So yeah, so essentially we can see that we go back, the cancer has been around and has been afflicting many of our ancient ancestors for a very long period of time. And you're going to see that, unfortunately, one of the things that one of the themes you'll see is that throughout the ages, dealing with colorectal cancer has not, unfortunately, been something that has not been able to be done very well because of the nature of these particular tumors. But when I went back, I thought I would just mention, just in regards to colorectal disease and how it was treated, because once again, this is International Pathology Day, so it'd be nice just to see, get a bit of perspective on what people thought and described, even if they couldn't really do much about it. And here's an interesting little fact. The ancient Egyptians, essentially, they thought that the abdomen was where all the diseases started, and actually had this actual specialist title. And this is a real job. There were different variations, but as the rough translation is shepherd of the anus. And essentially, this meant this was a specialist physician, and their sole job was essentially the digestive health of particularly the pharaoh as well, because they were really important about digestive health as well. And they realized back then what you ate often was one of the causes of disease. And as a result, they actually had a special title for that as well. Then we went on to the Greeks and Romans, and they were able to treat minor injuries and wounds as well. But you'll see that they actually couldn't really do much about colorectal cancer, because once a lot of internal cancers, and their treatment of cancer back then, and particularly, was just essentially cauterizing, so burning these types of tumors off. And I actually found this is quite interesting in ancient Egypt, India. I found this textbook, and within this textbook there was descriptions on numerous actually internal operations, including removing bladder stones as well, and also references to using an anesthesia in regards to cannabis and wine, and using using ants' heads, so essentially getting the large ants with their pincers to get onto the edge of the wounds and hold the wounds together, and then basically twisting the ant and leaving their head behind as well. And this was quite advanced when you actually compare to the rest of the world as well. So in India, we actually see that there was probably a lot more advancement in treating internal malignancy than there was certainly in ancient Egypt and in the Greeks at the same time. But as you'll see, unfortunately, most of this, we just really didn't get that much advancement in the world really until the 1800s. There was a lot of descriptions, and you'll see that I've got a couple of interesting descriptions here of essentially people describing colorectal cancer or internal malignancies, but not really knowing what they could do as well. And like I said, Hippocrates, from the Greek physician, Here, very good at, as you can see down the bottom here in this bottom sentence, talking about superficial skin cancers and burning them off, but with pastes and cautery, but obviously internal malignancies were a little bit more difficult. And then we look at Jean of Ardennes, and just a bit of history. He was an eminent barber surgeon, and one of the reasons that the English, or in the UK, the surgeons call themselves misters, is a lot of them were barbers and surgeons a long time ago. They weren't actually medically trained. And this gentleman, which was back in the 1300s, was one of them. He went and served in the 100 Years' War when England was fighting France, which is a lot more than 100 years. But what he did is he actually described colorectal cancer very well. This opostum, which is a hard nodule, and he describes it with great hardness and ulcerates and eroding through the anus as well. He describes it quite well. And you can see here that never be cured with man's cure. It says may never be, and I've never saw or heard of a man that was cured of cancer of the rectum, but I've known of many that have died from it. So they realized it was quite a horrible condition back there as well. But then as we go forward, and we'll see where I'm going with this, we'll see, because it all sort of starts to tie together. It's really in the late 1800s and the 1900s that things started to really progress. We started to get a bit more of a handle on all this sort of stuff around the world. And back in the early 1900s, this Theodore, a very gentleman, realized that there was more than one cancer involved, one more gene involved in cancer. And then in the 1920s, they described the polyps, the adenomas, and the carcinoma. There was an actual sequence of events. Before that, they didn't realize that they were linked. And then the knowledge started getting more and more. And only 30 years ago, we're talking 30 years ago, and I was only in high school back then, or just starting high school actually, Bert Vogelstein, he basically just developed this multi-step carcinogenesis of cancer. So it's a multi-step process, and actually described it. And with this concept of loss of heterogeneity, which is where you essentially have two defective, so you have one gene and then you lose another one, and you lose its effectiveness. So it's not homozygous, it doesn't, you lose it. So there's essentially, you don't have any more functioning genes. And this was something that around in 1990 that was starting to really sort of started to move things along. And this is just from a paper, just the interesting thing about 100 years ago, where they were describing, this is one of the first ones where this is from the British Journal of Surgery, where they essentially described how these tumors progressed, how they started as these polyps, and they described it diagrammatically. And this is an early histological section here as well. So we talked about, we got up to the 1990s, and we're just, once again, just a bit of perspective on it, because when we start talking about colorectal cancer, one of the first things that was described and helped describe the sequence was really this association with this condition called familial adenomatous polyposis, FAP. That's important because one of the genes that's involved in one of the pathways, which I'll discuss in a minute, this is where it was first described. But this actual condition, so the condition itself was thought far back as 1721, and there was a lot of debate backwards and forwards. And this Russian fellow here, and this is the paper in 1881. It's the first that actually had their first histological case. So before that, it was described with the naked eye, and he actually had the first histological case. And then they described the cancer, and then because people lived a lot shorter lifespans back then, it took a while to realize that there was a familial association with this as well. And they started describing that people that had this condition all ended up getting colorectal cancer. And the gene mutation was described in 1930 as well. On the flip side, and you'll see how all this ties in, Lynch syndrome, which is another cancer syndrome which represents one of the other pathways to neoplasia, was actually originally discovered by Dr. Scott Warfen, who Many of you might realize his name is associated with Warfan's tumor and Warfarin stain as well. But he actually noticed this family, which was named Warfan family G. And he came across this seamstress that was quite upset one day. And he was asking her, well, as the story goes, why are you upset? And he says, oh, I come from a family, I'm going to die of cancer because, you know, my relatives have died of cancer. So he took an interest in this and ended up looking into it. And he described this patient coming from a cancerous fraternity as well. Now, he described a bunch of cases, a small group, but it was sort of not, and I'll show you the paper, what he put together, but it was sort of described, and this was the first description of hereditary non-polyposis colorectal cancer, or Lynch syndrome. But Lynch himself didn't describe it till 50 years later, and that member of that family had grown to over 650 members. They'd have been able to track more people as well. And it was not until 1993, so about 3 or 4 years after we talked about this multi-step process, they actually described the genetic link. And this is Warfan, so this is Warfan's little pedigree that he did here as well. And just to show you, and colorectal cancer was a good cancer to help describe how essentially cancer genetics worked. And these, he noted there was a predominance of uterine and gastric cancers in the earlier generations. And hopefully you can see that I've just highlighted this. This is the uterine cancers. And then the red circles here are the GIT, so they describe it as stomach, intestinal, or abdominal cancers as well. So you can see that there is certainly a very big family trait here. And this is sort of genetics 101 with this. It has that sort of autosomal dominant pattern, as you can see. So it's mentioned 1993. So this is, we're talking about Lynch syndrome, and why was 1993 important in regards to colorectal cancer. So Vogelstein was the guy that was described this loss of heterogeneity, and that's this one of the most common pathways. But then at the same time, they were looking in this microsatellite. All these microsatellites were sort of discovered and described as well. And essentially, microsatellites, and we'll talk a bit about what they are in a bit when I get to the sort of meat of the talk in regards to the genetic association. But there's these, basically this is a little gel here, and we can see that these are repeating triplets. And he noticed, this gentleman, Manuel Pescuzio, knows that there were subtle changes in the lengths as well. And these were essentially these repetitive sequences he called microsatellites, and they're scattered all throughout the genes. So this happened about 1993. So he described this, but about the same time, or a little bit earlier, someone else that was working with this group that originally, with Vogelstein from Johns Hopkins, was looking at all these other genes in the classical pathway. And this Appelman was looking for a cause of Lynch syndrome, because once again, I've described that they knew that there was a syndrome and it was associated with these uterine cancers and so on and so forth. And anyway, by luck, I actually stumbled across these microsatellites as a cause. This microsatellites was actually the cause of these of Lynch syndrome, and the penny dropped, and there was this sudden rush to get essentially get this information out, and there was a battle to get the paper, and these group got their name out first as well. So as a result, they were the one that was credited with the discovery of a microsatellite and this link to Lynch syndrome as well. So let's all draw all that together. So what I've just described there in history is the two ways that we get to these two common pathways, and there are obviously many variations in between them, and everything is not straightforward in medicine, but just to put everything together, the two most common pathways that we are sort of familiar with. But there are other ones, which I won't unfortunately have time to talk about. So the ones that we are aware of are the traditional, the chromosomal pathway. That's the one that we know from the, that's the FAP associated one as well. And then the DNA mismatch repair deficiency, which is what Lynch syndrome essentially was the prototypical sort of was what was described as well, this microsatellite. So DNA mismatch repair, obviously mismatch repair deficiencies in the microsatellites as well. So these are the two common pathways. And unfortunately, I don't think the GIFs are working very well, so I do apologize for that. So the traditional one, which is what most of the colorectal cancers that we would see in practice are thought to have arisen from, are essentially this classical pathway, okay? And I've got a little bit more of a image on the next slide, but essentially just clinically, these tend to be more left-sided. So we all know that it's not always the case. And these are the ones that are associated with your tubular adenomas or your adenomas, and they precede the development of cancer for about 15 years or so, which is why we have a regular screening of patients once, or certainly in Australia when we do our bowel testing kit, if someone is found to have a colonic polyp, they will have regular follow-up, usually about 5 years, to make sure that we can capture any other adenomas or polyps that turn up and prevent them from transforming into a cancer, because we know that there is that length, that time frame. And this is the traditional pathway. Most of us start here. Luckily, unfortunately, if someone has FAP where they have loss of this APC gene, which I'll talk a little bit about why that's important in a second. But it's that classic two-hit, first hit, second hit, where you lose one tumor suppressor gene, whether you've lost the first one because you've inherited it, or you've lost it through a mutation, a somatic root mutation. And then you've got the second essentially as well. So that's where you get a mutation in your last functioning gene, and then you're already set up for problems because you therefore have a mutation, and depending on what gene that is, depends on how that particular entity will progress, and obviously not a cancer, but on the road to it as well. And then obviously as a result, when these things are happening, you get replication of the cells, and you tend to lose more and more of these important genes. P53 is an important tumor suppressor gene as well. And then obviously you get things like telomerases, which immortalize the cells. And then the cells start getting things like the metalloproteases and become more mesenchymal, and they invade into the surrounding tissue. So, but there is obviously, it's a sequence that we now know quite well. And we know that there are some usual suspects that are usually associated with it as well, and there is crossover, so you can get mismatch repair deficiencies. So the enzymes that look after these microsatellites can sometimes be affected in this pathway. So nothing is straightforward in medicine, but as a general rule, these are the types of mutation, your KRAS, your APC, your PIK3CA are the ones that you tend to sort of the ones that tend to be the most common ones. But APC is interesting because it's the first step usually, and it's the one that's associated with polyposis. And the question is, well, certainly when I was a medical student, was why? Why is this an important tumor? Why do you lose this? Why do we get polyps? And it's important, I feel, because it really helps understand how these tumors really develop. So APC is a type of tumor suppressor gene that essentially what it does is it locks onto beta-catenin, okay? Now, essentially beta-catenin and E-cadherin work together, and they're normal process in the body. So when you have cells that are stuck next to each other, everything's locked up together nicely, the cell doesn't want to go anywhere. But if you get damage and you lose cells, your normal cells will want to basically grow back to touch each other. So essentially it's re-epithelialized. When you get damage, it's a normal process. And what they do is they can't feel that they haven't got another E-cadherin touching another, essentially a tumor, another cell next to each other. They will essentially cause beta-catenin to cause this whole cascade of replication and so on and so forth until it bumps into another cell, and then E-cadherin gets activated and everything gets locked down again as well. And that gets locked down by APC. So if you get a mutation in your APC gene, it means that beta-catenin is free to essentially kick off and just do what it needs, just keeps on doing what it needs to be doing, because it's not inhibited. And as a result, it just means that the cells grow and grow and grow, and that's why you get lots of polyps, because essentially this gene just means that the cells will just proliferate as well, and the cell thinks that there's nothing being attached to it. That's what the message it is, and it grows. And you can see if it can't grow flat line, it will grow up, and that's where you get polyp formation as well. And I think that's important because it sort of really gets a bit of an understanding of what these particular little enzymes do and why they're important and how they can lead to tumorigenesis. And obviously you get something that's replicating, and as well, it's much more likely to get mutations. So that leaves us at the end of the traditional pathway, which we'll come back to some of the main players when we start talking about the molecular. But the mismatch repair deficiency, i.e. the microsatellite, which is we're learning more and more about every day as well, is the other player, and that's about 15% of colorectal cancers. Now, there's a couple of different things that can lead to it, and I'm going to say it a couple of times, is that we obviously have, you can just inherit a germline mutation, i.e. you can have a defective copy, and that's Lynch syndrome. So you're already born, unfortunately, all your genes have one less of one of these particular types, and I'll remind you of what these enzymes that repair these microsatellites. Or you can have this thing called the CPG island hypermethylation phenotype. Now I'll explain what that means in 2 seconds. So just a revision, remember microsatellites, they're those repeating nucleotides. You could see in that gel before we had like, we could see that they were like, it was quite a sort of regular pattern. And they're looked after by these enzymes that are basically, if there's any errors in them, these enzymes go along and fix them up. And these enzymes are made up of essentially two subunits, MLH1 and PMS2, and they stick together, PMS2 and MSH2 and MSH6, and these guys stick together as well. And these are responsible for fixing up any errors. And when we have errors in those nucleotides, depending on where they are, they can cause problems because if obviously they're in a tumor suppressor gene, they can cause loss of function, and to your proto-oncogene, they can activate it. So they're an important part of our cellular repair mechanisms as well. Now, these can be mutated in a different couple of ways. And when they get mutated, and I'll talk about how they get mutated in a bit, it's sort of a similar sort of process as well. Once again, if depending on how if it gets mutated, or you've inherited it, or it gets methylated, and I'll talk about that in 2 seconds, it has a sort of knock-on effect again as well. Obviously, you start losing your ability to repair, DNA, and then bad things happen because you start getting errors in your genes that you don't want, and it leads to a certain actual particular, a certain sequence of oncogenes that are sort of activated, and BRAF is one of the things to think about, and I'll talk about that in a bit. So what leads to this microsatellite instability type, this second pathway? And even though it makes only 15% of them, what leads to it? Well, you can have it sporadic, which is the most common one, which is just bad luck. And most of the time, and I'll explain a bit, is due to this methylation process. Or like I said, you can be Lynch syndrome, you've inherited a copy of it as well. And Lynch syndrome is the one that certainly has criteria that's associated with it. And we know that it's a syndrome, so therefore we have all these sort of like criteria on who should be tested for it as well. So the bad luck people, so the people that have got these 15% odd tumors, the ones that get this microsatellite instability DNA, DNA mismatch repair turned off, what happens? Well, most of the time, they don't actually get a mutation in the actual disrepair enzyme. What happens is they actually get the gene is turned off. And this is an important thing that we're starting to think a bit more now about, is called epigenetic silencing. And essentially that means is that the body, for some particular reason, ties down the enzyme, so this repair enzyme, it basically gets methylated on and I've got a better one here as well, and turned off. So the actual enzyme itself is still there, but it's not working. It's hypermethylated. Essentially, it's just the body sort of stuck it onto the histone and it can't unravel. And that's sort of unfortunate because it means that it has the same effect as a mutation, and it means that we lose the ability to repair those microsatellites as well. And that's what we mean by this CpG isomethylated phenotype, or the CIMP, which is what you'll see that in the literature. Now, there is a strong association with BRAF V600E, and they don't really know why. So unfortunately can't tie it in with some sort of crazy sort of correlation, but they are still trying to work it out. But there seems to be a high association with a BRAF V600E mutation and this epigenetic silencing. So if you've got bad luck and for some reason your body's turned this off, and you've got a cancer that's resolved from it, you've got a pretty good chance that you'll have a BRAF mutation, and that's something that we can test for and suggest a sporadic mutation as opposed to having Lynch syndrome. And we can test for hypermethylation as well. But as anything in medicine, you can also just have bad luck, and you can still just get mutations in those mismatch repair genes, but they tend to be a lot rarer. And this is just another picture from a leukemia, just the same thing, essentially just talking about turning off these genes. So the familial type of the DNA, so mismatch repair, so microsatellite this is Lynch syndrome, and obviously you inherit it from your family, and it's a classic second hit theory, so you get bang, you've already got the first hit already, so you only need one more mutation to put you over the edge. The most common genes involved are still MLH1, but MSH2 as well is one of the more common things as well. Now, these genes are not silenced like in the sporadic, i.e. the bad luck version. They're just mutated. You just got somatic mutation as well. So this is probably a revision for a lot of you, but how do we sort it out? How do we tell if we get something that we think is a microsatellite unstable tumor? How do we, or a DNA mismatch repair tumor? How do we sort it out to say if something is more likely to be germline or not? Well, there's a lot of literature out there and flowcharts, but this is just one that I'm just going to talk through just to show you an example. But essentially, we do immunohistochemistry, which is probably the first port of call. In our lab, we actually tend to do it on everything now. I know, so we just do it on all tumors as a bit of a knee-jerk reaction, reflex testing, sorry, I should say knee-jerk, as a reflex testing. And so we normally test, some labs just do 2, we do all 4, and then if, depending on what the result is, we will add on a BRAF test or not. So this is the most common form. So what we'll do is we'll do the tests, and say if we find that we get loss of MLH1 and MLH1 and PMS2, remember they associated together, so you tend to lose both of them. If we lose both of them, then we will proceed to do a BRAF immunohistochemistry. And if that's positive, and that's for V600E, that would highly favor a sporadic mismatch repair deficiency through bad luck as well. Now, if it's negative, it's more likely to then you can do methylation tests as well, which you can send off for, or essentially, if it's not methylated, then it suggests possible Lynch syndrome. But then if any of these other markers, so it's MSH2, MSH6 is deficient, any of those ones means probable Lynch syndrome, or PMS2 by itself, if that's mutated, and that's rarely, but I've had a case recently of that, that would also suggest that it's probably associated with familial cancer syndrome as well, and they need testing. And we mentioned about inflammatory bowel disease, but inflammatory bowel disease is an important thing to think about. because it is associated with colorectal carcinoma. And though ulcerative colitis tends to be thought to be the higher risk, when you sort of put everything together, the overall data is probably about the same. And it's a pretty high increased risk. We're talking almost like a 20 times increased overall risk. And this is for people that are poorly controlled. And most of these cases, 3, 4, so 75% of cases will have dysplasia when we look for them as well, which is why it's important. One of our roles as pathologists is looking for dysplasia in these inflammatory bowel disease patients. And that's a whole talk for itself. There's a lot of interesting papers on that at the moment. But the increased risk of getting cancer with inflammatory bowel disease is, there's some risk factors, and some of this makes sense. So an earlier age of disease, the extent of disease, so having primary sclerosing cholangitis with ulcerative colitis is not a good thing. That tends to increase your risk even more. And having a family history that's sort of independent of the inflammatory bowel disease obviously makes the risk even greater as well. And just to touch on this is that there is a different molecular pathway. So the more work they do it, they actually suggest that it's more to do with loss of these particular type of genes as well, these P53, P57, such alike, as opposed to microsatellite and your traditional pathways. And there's all more ongoing research on that as well. And this is just to get a flavor of it. We've talked only really about these two stereotypical tumor syndromes, but there's a hell of a lot. And this is from the WHO, the recent WHO, and how many different sort of described genetic syndromes that are out there as well. You've got even these proofreading pole type mutations as well. This MUTHY associated polyposis, this third one here, which is your attenuated FAP. So there's a lot of these ones around. All right, so let's go into a bit more pathology now. So let's look at colorectal cancer under the microscope, and we'll go back in time a little bit more. And obviously when the microscope came, we were able to see tumors a little bit better. Obviously the microscope has been around for a while, and that previous slide was back in the 1600s, but the magnification wasn't that high. But and we also didn't have the stains, but as they got developed, we were able to describe these things a bit better. And interesting enough, this is a paper from 1932 that actually described conventional carcinomas and started describing colloid carcinomas, and carcinomas that they thought didn't basically metastasize extensively, but then they talked about signet rings. So there was, as we know, having signet rings in a carcinoma is a bad thing. So there was probably, they didn't realize that either as well. And also having mucin affected the mucin production, they thought affected the grade as well. So obviously the more glandular it was, and they weren't far off that. And this is just some micrographs from that as well. So we can see here, this is your standard one up at the top left, and then you've got our sort of more mucinous carcinomas on your right. And this is interesting, and they've got the bottom one on the left, they describe as a grade 1 tumor, and with lots of what they called mucin/goblet cells. And on the right, they call this a grade 4 tumor, and you can see it's very solid. And it's probably not far off. They made that, the more poorly differentiated it became, the worse it acted, and that's pretty much what we sort of think nowadays as well. So why do I bring that up? Because we've come a long way since then, and obviously our the way that we approach these things are different, and we have lots of subtypes now. Some of them come, some of them go, but we settled on a couple in the recent WHO, and I'm just going to show you a couple of pictures. But why do we worry about it? Well, some of them are associated with those particular pathways, so microsatellite instability. Some of them have a worse prognosis, and some of them doesn't really affect the prognosis, but can be difficult to diagnose. So this is a mucinous carcinoma here. This is our signet ring carcinoma. This is a bad carcinoma to have. And there was something on Twitter recently about a particular case of this. So the definition in the WHO is more than 50% signet rings with prominent cytoplasmic mucin. And this tends to be more right side of the colon and in younger patients. And it tends to have a high, so these tumors tend to be more likely to have microsatellite instability as well. And they have a generally bad prognosis as well, as most signet ring type tumors tend to as well. As you can see with this tumor, this is a real case of, unfortunately, had recently. You can see that it's gone all the way through the walls. It's a very high grade tumor as well. And obviously the differential diagnosis with something like this is looking for metastatic disease as well, because obviously signet ring carcinomas are renowned to metastasize all over the place. Then we've got this nasty tumor, micropapillary carcinoma. I'll wait for it to update. And this is one of the only tumors that I've diagnosed as a T1N2 tumor. And these are very aggressive. And anything micropapillary, as you probably are getting a feel for it, generally means bad news. So essentially, this is a very aggressive form of tumor. And to be classified, it needs to have these small nests of tumor with retraction artifact. And interesting enough, you only need 5% morphology for the diagnosis, though the papers sort of tend to think that 10% is the point where it really makes a difference. Though that's what the new WHO says. So if you have more than 5%, you can call it. And obviously that's a very subjective number and probably a lot of intra-observer variability in that as well. But it's a bad news tumor, and like I said, it's very, very aggressive. And then we've got this next entity, and this is the medullary carcinoma, and it can look like sheets and sheets essentially of tumor cells. It not look like a colorectal carcinoma at all sometimes. It has these prominent nucleoli with lots of cytoplasm. It has usually a sprinkle of inflammatory cells, or quite a number of inflammatory cells actually. This one has a lot. This is unfortunately, I couldn't find my case in time, so I had to borrow this from the WHO, but it pretty much looked like the one I had recently. But there's a lot of lymphocytes in this as well. Now, why do I bring this one up as well? Is that usually a lot of associated microsatellite instability and this is usually with BRAF mutation as well. And that's sort of important because these tumors quite often lose, especially when they become metastatic, but often just initially, and I've had another one of these difficult tumor biopsies where CK20 and CDX2 can often be negative in these tumors as well, though the lack of this microsatellite type with BRAF positivity was actually quite useful, and also the clinical. But it's worthwhile thinking about that as well, because like I said, we always rely on these markers, but there are tumors out there that don't necessarily express it. Now, this next case is it's a little bit contentious and so on and so forth. It used to be called a villus carcinoma, or now the WHO refer to it as an adenoma-like carcinoma. And this is a difficult tumor because it invades with a pushing water, so it bulldozes its way through the tissue with very little desmoplastic response, and it has to be more than 50%. And the problem with this is just hard to diagnose and biopsy. This is one I usually go and talk to my surgical colleagues if they've given me something like this, especially if I've read the endoscopy report and they say it's a big tumor and all that sort of stuff, and I'm only seeing what sometimes we think at the top of it might actually be quite further down. And you can see this tumor is quite invaded quite deeply down here as well. I think this is even the muscularis propria it's pushed into. So this is a difficult tumor to be aware of that you can diagnose on. It's difficult to make a diagnosis on biopsy, and I had one recently on a polyp. So yeah, we get to show it around a bit because they can be quite difficult to diagnose. But be aware that they do exist. All right, so let's just change tack a little bit. So we've talked about the histology. we're coming towards the end a bit now, but we'll talk about the staging system, and I won't go on about it, but essentially the staging system is something that's been around for about 60 years, and before it was all a bit of a mess in regards to that everything had its own staging system, and we had Duke's staging system for rectal carcinomas, and we have this modified Duke's or revised Duke's staging, which lines up with the WHO quite nicely, with the TMM quite nicely. But some of the older surgeons here still refer to it as well. So it's something that people still refer to. So what are the challenges that I find with staging? And I think that there's an interesting couple of articles out there about this as well. And this is something that I've come across, is I always find it difficult when we're looking at staging in regards to the PT4 and the PT3, i.e. has the tumor invaded through the serosal surface or not? And there's a bunch of papers about, is there any mesothelial cells? How far away? Is there an inflammatory cap? About a discussion about that, and I'm not going to bring up any contention about it, but it's to say that's something that we need to look into, because some suggestions are maybe we're under calling, while some other people would say maybe we're over calling it as well. But it's certainly something, because obviously if someone has a PT3 with no nodes and a PT4 with no nodes, certainly in our institution that is almost a cutoff point for chemotherapy. The Y stage, and this is something else that it was in a good paper. I think I have attached it at the references, that people calling acellular mucin as in a treated tumor as a N1 when it should be an N0, sorry. So N0, acellular mucin should be. So this is some of the problems we're having with staging, and also just this concept of small lymph nodes, a small amount of tumor cells in lymph nodes, this so-called isolated tumor cells. Now, it's done well in breast cancers, but unfortunately, another paper was done in modern pathology with some people recognize Ranjan Chutney. Ranjan Chutney was one of the authors, sort of was mentioning that if you look at the new AJCC TMM, that isolated tumor cells don't affect the end stage, and you should mention them, but they don't. And a lot of people are calling a couple of scattered cells positive, and that's probably something that we probably shouldn't be doing, because we may be over calling it as well. So I think it should be noted, certainly in a report, but it needs to be aware that they are not now counted as positive nodes. All right. Now, tumor budding, before we start getting onto the molecular stuff and then we're finishing up, is something that was discovered right back in, or described back in the 2000s, that essentially has essentially sort of like went off, and now it's much more interesting now as well. It's essentially at the advancing front of the tumor, are there more than like 1 to 4 little nests of tumor cells? And you look at a ×20 field, and if it's more than a certain number, it's a 3-tier system. It gives a risk, so low, medium, or high. We do it here. It's very important, I think, in malignant polyps for risk stratification, and that's something that should be done on H&E, and it's certainly something that's becoming a bit more common. And it's interesting that we did have it about 20 years ago, and then there was a couple of papers, and then it all went quiet, and now it's back in fad, and they actually think it is a very important prognostic factor. And to touch on this, because we're going to move into the genetic stuff and the genetic markers that we need to know about, but just to know that there are proposed molecular classifications of CRC, and I mean that by colorectal cancers. The genomic, which is essentially looking at the genes, and the transcription, looking at what's being expressed. And there's a bunch of different papers on it as well. With the genomic ones, they call these things hypermutated or ultra mutated, which are those pol type tumor, the proofreading enzymes, or the non-mutated, and they sort of nicely snug into either the chromosomal instability and MSI pathways as well. The transcriptional one, there's more there is certainly more work being done on that as well. So unfortunately, the transitions aren't going to work very well on this. So just wait for a while while it updates. So molecular. So we do molecular here in Liverpool Hospital. We have our little we have a genetics lab here. And it's important because it helps with doing all this molecular work on top of our immunohistochemistry. Really helps give us some information about how a patient's going to respond and what their prognosis is as well. And in particular, in regards to response, are they going to be resistant to certain treatments? And also, there are certain future targeted treatments that are important as well. So I'm going to talk about RAS now. And RAS oncogenes, we talked about in that traditional sort of pathway. Remember, it's when we treat with these EGFR antibodies, and RAS is downstream, essentially from EGFR. And if you get this, and it's a signal pathway, so EGFR gets signal to tyrosine kinase receptor, and it kicks off all this down to the nucleus and essentially causes cell replication. So if we block it, that's great. But if we have a mutation downstream, it will lead to resistance. So EGFR inhibitors are used usually in metastatic colorectal cancer. And if you have a KRAS mutation, it will predict resistance. So it's important, you don't want to give patients unnecessary treatment. So BRAF I have mentioned before. Unfortunately, even though we know that we can target it with other tumors, colorectal cancer seems to be a little bit more difficult for targeted inhibitors as such, though there's still work on it. But it's part of that whole signaling pathway. And again, it predicts response to treatment, so EGFR inhibitors as well, and it means more resistance. So here's some other biomarkers that are probably going to be coming in the future. And the two ones I'm going to talk about is PTEN, PTEN, which you might recognize as something that they use in endometrial atypical hyperplasia. It's a loss, you lose it. It's a tumor suppressor gene. So once again, your loss of that maybe causes resistance to EGFR. And PIK3CA over here, I'll go similar sort of downstream mutation as well. So these are all future possible predictive biomarkers. So CDX2 is another one. This is a paper that was released a couple of years ago. I can't remember, it was about 40 or 50 patients, I can't remember. But essentially what they were saying is T3 tumors with no nodal involvement, so stage 2 colorectal cancers, so tumors that are T3 with no nodes, but if they lose CDX2, may suggest a higher risk and might be a decision point for giving chemotherapy as well. And there's certainly more work coming out on that. I've been asked to do a couple of these stains. My problem I find is having a proper scoring criteria for if you've got a bit of an equivocal result, and what does that mean? So cancer immunotherapy is the big sort of thing at the moment. I feel we do a lot of staining for PD-L1 in our department for lung cancers, and we're doing it for breast now as well. You may also know that it's been done for melanoma. It's essentially that the tumor hides from the immune system and sometimes tells the T cells to undergo apoptosis because it actually has this PD-L1 receptor on it. And what we do is now we block it, which is great. Now in the colorectal cancers, it's usually, well, it is the microsatellite in unstable, so the MSI, the DNA mismatch repair enzyme type as well, not your sporadic ones. And it's overall, it's a smaller set of patients than in other tumors generally. And there's obviously ongoing research, but just as probably a lot of you have seen, these particular type, or read at least, these particular type of immunotherapies are not benign. They can kick off a bunch of different side effects, especially a lot of autoimmune type conditions, and certainly we've seen our fair share of side effects from these drugs, autoimmune colitis, autoimmune gastritis as well, are some of the ones that I've certainly seen in the last few years. And it's certainly something to think about in patients that have been recently diagnosed that come in with a funny symptoms as well. And I think that's one certainly thing I tell my clinical colleagues and more so the medical students when they're in the emergency department and out there, think about these drugs and these treatments as well. All right, so what's the future? I'm almost finished. So what we're doing at Liverpool Hospital and the Ingham Institute and Western Sydney University is looking at this DNA response pathway. And it's I don't have enough time to talk about it, but essentially we've got a bunch of different pathways to repair. Essentially, you're turning to repair breaking double-stranded DNA, and whether it's single or straights. But essentially, you're turning off these repair enzymes. That means that it's quite complicated, but essentially one gets mutated in the tumor anyway, and it's all to do with BRCA mutations. But if the patient doesn't have a BRCA mutation and it's turned up, they call this PARPiness. This is what they talk, and essentially it causes the cell to cause more damage to its own, the cancer cell to do more damage to its DNA and kill itself, because essentially this other pathway is intact in normal cells, but in mutated cells it's usually lost, which is what led to it. And you're sort of using the tumor's mutations against itself, but that's in the future. So my PhD that I'm finishing off is on autophagy markers, where autophagy, remember, is you might have read, is essentially where the tumor under stress uses its own organelles to survive. It's a survival type thing. It also has some tumor suppressor roles in normal cells. Unfortunately, you don't want, and certainly it's proven in other cancers, but you don't want this thing happening in cancer cells, because if you've got autophagy, if the tumor cells can do autophagy, they can resist chemotherapy and all that stuff, and that's not good as well. And lastly, there's something called this T-cell transfer therapy targeting mutant RAS, and there's a paper there if you want to look it up in the New England Journal of Medicine. So we're at the end of the summary. What do I want to talk about here? So colorectal cancer has been around for a long time, since the beginning. But our understanding in the last few years has grown exponentially. And understanding the molecular pathways is really important to understand how we treat and diagnose tumors and where the future direction lies. And on a side note, subtypes do matter of tumors, because they can predict and they can tie into the molecular pathways in some ways, but they can also predict prognosis as well. And lastly, making sure that we're getting our staging correct is really important. So that's the end of my talk. So happy International Pathologist Day, everybody.
Super, Tristan.
Thank you. I'm sorry, I can't hear you.
Dr. Tristan, can you hear me?
Yes, I can.
Yeah. So firstly, let me just congratulate you and thank you for that excellent talk. I think you remain true to your heading, right? You talked to us right from mummies who had metastatic cancers from ancient Egypt. And then you took us through an entire gamut of, how the colorectal cancer progressed. You also took us through the different, eras, the modern era, and then you told us about when FAP was first diagnosed. I think that's extensive. I love history, so it was beautiful. You took us through the entire thing. And then you took us through the histology also. See, now colorectal is a huge spectrum. And two very important things that you mentioned was the medullary carcinoma. That's something very interesting and new. And adenoma like adenocarcinomas, which you mentioned as a histological subtype in the new WHO. And then again, as I said, true to your topic heading, you took us through the pathways of colorectal cancers. You mentioned about the sporadic and the familial variety. And then a little bit a tweak on IBD and colorectal cancer, which definitely remains a very, very important aspect of colorectal cancers, and that something that we should be aware of. And then, of course, the recent ones which have erupted in colorectal cancer, the tumor budding, and then the molecular classification, which might become very, very relevant in course of time. And finally, of course, you ended up with the cancer immunotherapy. And the last slide was really, really thought-provoking because it leaves a lot of ideas for research on colorectal cancer, where you talked about PARPness and PARP, which really has a target, which can be a part of the targeted therapy, the autophagy markers and T cell transfer targeted, targeting against mutant KRAS. So it's a complete, right from mummies to right to the molecular. So I really congratulate you, Dr. Tristan. I think it was so very framed, and I think it was a lot of knowledge learning. I think there are a lot of, maybe there are some questions and interaction, but before that, Dr. Tristan, I have a couple of questions that I would want to ask you.
Sure.
May I?
Yeah, of course. Yeah.
So you talked about adenomas, which occur roughly about 10 to 15 years before adenocarcinomas. So how do you screen and follow up in Australia? Do you do any molecular testing in adenomas? So how do you just follow up your patients who have adenomas?
So generally, it depends on what sort of adenomas they have in their family history. So we have a national bowel cancer screening program in Australia where everybody over the age of 50 gets a fecal alcohol blood test. And then based on that, they will then, if it's positive, they'll have a colonoscopy. About 25% of them will have an adenoma and 5% will have a carcinoma. And then depending on the adenoma will be, and a bunch of other factors will be follow up. So it's usually about 5 years for sort of tubular adenomas and 3 years a bit shorter. Then we also have a bunch of other things that if patients have a strong family history, they just skip the screening and go straight to surveillance as well. But we don't do molecular testing, certainly not in the public hospital on polyps as a start, such as well. They might get testing if someone else has had like familial carcinoma.
There are some questions here on the screen that I see, and maybe I'll have a couple of questions later then. What are the features to look for to diagnose micropapillary carcinoma? You did mention about micropapillary carcinoma. So how do we look for it?
So from my point of view, it's that real retraction artifact. So that's one of the key features I find. Can you hear me?
What are the features?
Yep, sorry.
Yeah, we can hear you. Yeah, we can hear you.
So one of the things that I look for particularly as well for micropapillary carcinomas is essentially that sort of small clusters of cells in what might look like to be vascular. So that retraction artifact is the thing that I really look for as well. And one of the things I find, and I know it's a bit of a soft sign, but if I see a tumor that's got a lot of lymphovascular invasion away from it as well, that's another sort of key to it. But it's that real sort of, and the thing is you've got to go looking for it, because sometimes it can be quite focal, because the guidelines only say 5%,
yes,
which my experience, they tend to be a bit more than that. But sometimes, yeah, the areas can be quite focal. So it's like any of those sort of micropapillary type tumors, those small sort of nests of tumours with a retraction around them essentially. But I just find that one of the finds that they always tend to have a hell of a lot of lymphovascular invasion.
Yeah, thank you. The next question is it mandatory to do an MSI testing in all cases of colorectal cancers?
So in our institution, what we do is we do it on all colorectal carcinomas as well. And so I don't think it's mandatory to do it, but certainly, and there's obviously the guidelines that talk about, is it the patient above, which I put up the revised Bethesda guidelines. But we just find from experience, we just do a reflex test on all of them as well. And we're concerned that we might miss a couple. So no, it's not mandatory, but we just do it in our institution on everybody as well. But there are certainly, like in those revised guidelines on, is the patient over a certain age? Is it a right-sided tumor? And I'm just trying to see if I've got it here, but that's what we do as well. So, and we find.
So you do both IHC, yeah. As an extension of that question, you do both IHC as well as the molecular in one go, or you do one after another?
No, so we just do the 4 markers, and some institutions will only do 2. They'll do MLH1 and MSH2, but we do all 4. And then if we have an MLH1 PMS2 loss, we then do BRAF, IHC as well. And then if that's retained, no more. And if it's not, then at our multidisciplinary meeting with the surgeons, that we have a geneticist there that will then go do further testing.
Right. Okay. Thank you. How do you screen the family members? Is there any guidelines available? And what sample do you prefer? Would you do it on tissues or would you do it on blood samples, Dr. Tristan?
To be honest with you, that's probably a little bit beyond my remit in the actual what samples they use for it. I'm not a geneticist.
Okay.
But certainly my understanding in Australia, yes, so there's a clinical geneticist that will do that. We also have guidelines in regards to high risk and medium risk and low risk patients with family histories. And in regards to screen, if those people have a high risk, they won't be screened, they'll be actively surveilled. And they usually surveil, so if a patient has a high risk of colorectal cancer in their family, they will start surveillance 10 years before the first person in that family got their cancer. So if they got cancer when they were 35, they'll start screening family members that are associated with that at 25 years old.
Oh, right. Yeah. Another interesting question, one that would be useful for, I think, everyone. Any particular diet that may be associated with the risk of developing MSI-CRC, Dr. Tristan? I mean, has there been any associated papers or any work in your institution regarding that?
To be honest with you, I actually don't know the answer to that one as well. I certainly know that obviously, high income countries where with a lot of obese patients with alcohol and stuff, we have a higher risk of colorectal cancers. But I don't know if there's really sort of like, I don't know really the answer to that question. One interesting thing I do know is that there is, into regards to dietary as well, there was some evidence about using NSAIDs to reduce polyps, which I thought was an interesting little thing. So using non-steroidal anti-inflammatories, which was an interesting. I used to be a pharmacist before I did medicine. I found that.
Okay. Okay. Right. A small portion of Lynch syndrome related tumor will not show evidence of MMR deficiency sometimes. So how do we go about in these cases? I mean, how would you detect such situations?
Well, I think in those cases, if you look at the guidelines, it's really based on going back to the criteria again as well. If there's a strong suspicion in the family, I think, and once again, I'm not a clinical geneticist, but my understanding of this as well, you go back to the guidelines and you look through what the guidelines saying. If there's a strong family history, though, it should be tested in that case as well.
Dr. Tristan, I think your voice is not clear.
Sorry. So it's essentially going back to the guidelines. If there's a strong suggestion in the family history, I think regardless if it's not possible, if it's not positive, you should, they will then test it anyway.
Dr. Tristan?
Yep. Can you hear me? Oh. Can you hear me?
Sir, can you hear us?
I can hear you fine.
Okay, so we have few more questions which is being just asked by the participants. Is age, site and radiology finding help in genetic testing? This was asked by Dr. Nilesh.
So age, site, yeah. So I think it does. With that sort of like caveat of not everything is straightforward in medicine, but that whole right-sided younger patients tends to be associated with your more microsatellite unstable tumors. Does hold true a little bit, but with the caveat that nothing is straightforward in medicine, and you do get left-sided MSI in younger patients as well, and older patients as well. So yeah.
We have another question for you, sir. Please share little information about tumor infiltrating lymphocytes in colorectal cancer and how it is being scored. This has been asked by our very own postgraduate, Dr. Maunika Reddy.
So tumor, sorry, the question was, so I missed the last bit of that.
Please share little information about tumor infiltrating lymphocytes in colorectal cancer.
Super, madam.
Yeah, so tumor so in particularly looking at, so there is an association with tumor sort of infiltrating lymphocytes, and it's interestingly enough that that can sometimes be associated with this Crohn's-like reaction, and it's generally associated with a better outcome. Funnily enough, and I wish I had prepared a slide, one of the things that I find quite interesting is that the amount of tumor infiltrating lymphocytes is actually not that much. And when we score it in our institution in particular, you only need a small amount as well. But interesting enough, and a lot of these things were done with immunohistochemistry, I find that it's quite often undercalled. Because the actual studies have been doing when they look at actual CD3 and CD8, but we don't tend to routinely do that on all our colorectal tumors as well. So essentially, to answer the question as well, it has a better outcome as well, but the difficulty is actually getting that diagnosis correct as well on H&E.
So, she also wanted to know TIL scoring, number of fields to be considered. How many fields has to be considered for scoring TILs?
Well, that's an interesting question as well. I'd have to really sort of look at what the standardized data with that as well. My experience with this as well is that I tend to just look at about 10 fields, but I'd really like to, I'd actually have to find out what the recommendation for that particular thing, that particular paper is at the moment. If you give me 2 seconds, I can give you an answer for that, because I'll just look it up, because it's sort of beyond me at the moment. Can I give you the next question? I'll come back to that one if you like.
Yeah. What is the frequency of MSI and other testing after diagnosis of colorectal carcinomas? What is the frequency of MSI?
So what's the frequency of MSI, sorry, in regards to?
What is after diagnosis of colorectal carcinoma? They just wanted to know what is the frequency of microsatellite instability.
So microsatellite instability is about 15%. So 15% of sporadic tumors overall. Is that so? Like if you sort of put them all together, of MSI, about sporadic tumors, colorectal cancers overall, to about 15% will have microsatellite instability. as well. Sorry, is that what you're after? Sorry.
Yeah. Yes, I think probably you would have answered right to the questions. Okay, so we have another one. What about subserosal, serosal, periserosal fat involvement in staging of colorectal cancers? This is by Dr. Jayalakshmi.
So in regards to serosal, so what was the sorry, Miss, what was the question that was like
regarding staging? What about the subserosal, serosal, and periserosal fat involvement in colorectal carcinomas?
So yeah, so T3, so if it invades into the subserosal fat, it's a T3 tumor, but I always find it's the serosal involvement that is always the tricky bit, because from our point of view, that's a T3 to T4 diagnosis, and that's the bit that's not done very well. And I'm not quite sure if this is what the question is, but I find that that's something that really I feel needs to sort of have I think needs to have a bit more consensus on, because a lot of people will call subserosal involvement with a bit of inflammatory cap over it and no mesothelial cells are T3, or some other people actually call that a T4. And I think there's a lot of inter-observer variability with that particular area as well. So I don't think there's really a straight answer for that particular question, because I think that if that's my understanding what the question's about. The only other thing, as I just say sometimes for the registrars as well, is that if they need to go looking for funny fat, like if the fat looks a bit unusual, be worried that the tumor is actually not invaded into there's not mesentery stuck onto it as well. And quite often that I find that you've got to be very careful, because if you've got, I'm putting in inverted commas here, funny looking fat, and you've got, you know, mesentery that's stuck on and the tumor's invaded into that, that's not T3 anymore, that's T4.
We just have the last question for the day. How to differentiate between T4A and T4B on histology? This was asked by Dr. Mohammed Asif.
So T4A is just the tumor is breached to the serosal surface. So it's exposed to the peritoneum. But T4B is it has to have invaded into a separate organ. Now that's not like from the cecum dividing, you know, going along the cecum into the duodenum. That's still essentially T2, T3. But this is the tumor invading into into the serosal surface and exposing essentially the peritoneum to the tumor, and that's A. And then when it invades through the serosal surface and then invades even further and sticks on to another organ, that's T4B.
Thank you so much, sir. So over on to Rajendran, sir, to present certificate of appreciation to our speaker.
Thank you very much, Tristan. It's an excellent talk, and I like the discussions. It was very lively, and it tells you the quality of your talk and the quality of the people who are listening to it. It's a nice feast on the International Pathology Day. And Poitra, can you put on your camera also when I'm presenting the certificate to Tristan? So it's my honor to present this online certificate to you, and it's one of the thing we do. Unfortunately, we are not able to host it in physical form, otherwise we might have shown our hospitality better. But I take this opportunity to give you this certificate of appreciation. Thank you very much.
Thank you very much. And thank you very much for giving me the honor of talking at your International Pathology Day. It's always great to be able to communicate with our colleagues around the world, and I really enjoy getting to know you all, and certainly through this and through social media as well. And I really hope that we could have more to do with you guys as well, especially even though the virtual world has brought everybody a lot closer together now, which is, I think, is fantastic, certainly for the profession as well. So thank you.
So over to Dr. Bharati, Organizing Secretary, for the vote of thanks.
On behalf of the entire organizing team of Sri Ramachandra Medical College and Department of Pathology, at the outset, I would like to thank our Chancellor, Pro-Chancellor, our Vice Chancellor, and the entire management team for providing us this platform even during this difficult times, so that doesn't deter our interest to learn from various speakers. So I would like to thank the management first, and our dynamic HOD, Professor Dr. Sandhya Sundaram, who has been guiding through all these years with a great encouragement to all the youngsters in the department. Thank you, madam. And if I would be failing in my duty if I don't thank Professor Dr. Rajendran, who is the key person behind this entire program, who has brought in the speaker. So thank you, sir. And of course, Dr. Tristan, for this beautiful talk on the colorectal carcinoma, which is what is the recent advances. Much learning has happened to our entire postgraduates and all the pathologists on this day of International Pathology Day. Thank you, sir. And I would like to thank Dr. Pavitra and all other my colleagues for helping me to organize this event today. And I'll be failing again if I don't mention my communication team of Sri Ramachandra, who were there throughout to organize this event. Thank you all for, and of course, last but not the least, all the participants. Thank you so much for logging in. And I also kindly request you to give us a feedback survey that will be sent to your mail. And also you can collect your e-certificates that was also mailed already to your IDs. Thank you so much, everyone. Thanks, Dr. Tristan, and thank all the participants also. Thank you.
Thank you all. Thanks to all the delegates and speaker, and we wish you again a very happy International Pathology Day. Bye-bye.
Thank you.
Thank you very much, guys.
Thank you, Tristan. Have a nice evening.
See you later.
Bye.
Take care. Bye. Bye.
We enjoyed it. Bye-bye. Super.